Hey everyone, welcome to the 20th installment of the Inside JABA Series on behavioral observations. In today's episode, I am joined by Doctors Brennan Armshaw, Manish Vaidya, Sachen Mehta, and as always, Editor-in-Chief Dr. John Borerro. In this episode, we discuss a fantastic paper that is now available in the summer issue of JABA. It's called Surface Electromyography-based Biofeedback Can Facilitate Recovery from Total Knee Arthroplasty. In brief, this is a study that examined a novel treatment approach for rehabilitating patients following knee replacement surgery. Orthopedics is something that's been on my mind lately as I am recovering from a broken metacarpal bone in my hand. And as an aside, if you want to see the x-ray of it, I'll put a picture of it in the show notes for this episode. However, even if you're not interested in orthopedics, I really do encourage you to dig into this episode for no other reason, but it's just an amazing case study of applying our science to a novel problem that affects millions of people. As always, there are no advertisements in these Inside JABA Series podcasts, but I will mention that if you'd like to get a CEU for listening to this episode and answering a series of questions related to its content, you can find out how to do just that over at behavioralobservations.com/get CEUs. There, you'll find not only all of the Inside JABA Series podcast CEUs, but many others as well. So if you'd like to learn from your favorite podcast guests, especially while you're on the go, check out what we have to offer over there. I should also mention that there are discounts available for multiple CEU purchases. I recently crunched some numbers and found that CEU customers on average save sometimes over $100 when they leverage these discount codes. So again, check out what we have to offer over at behavioralobservations.com/get CEUs. And while you're at behavioralobservations.com, go check out the show notes to this particular episode. These show notes will be especially helpful. I've cut and pasted the figure from the study that we talked about, and it's one of those things where picture says 1,000 words, if you will. And there'll be other links to the authors' affiliations, etc. So if you'd like to track these people down, if you have a follow-up question, we can make sure that you know where to reach our guests for today's episode. And again, I'm very, very grateful for their willingness to spend some time talking about this very important work. So without any further delay, please enjoy the 20th installment of the Inside JABA series on behavioral observations.
Welcome to the Behavioral Observations Podcast, stimulating talk for today's behavior analysts. Now here's your host, Matt Sikoria.
Hey everyone, welcome to the 20th edition of the Inside JABA podcast series on behavioral observations. This episode is very special it is the 20th one, so I think for some reason, big round numbers are reinforcing. And so it's kind of cool that we've strung 20 of these together, thanks not only to John, but thanks to Dr. Linda LeBlanc, who, this was, let's be honest, this was kind of her brainchild. So anytime you hear one of these episodes, it's definitely her vision in terms of her editorship. And I think we're all grateful for that. The second reason why this particular part of the series is special is that we've got a very unique topic here. And so we're going to talk about behavior analysis applied to a very novel application. We'll get into that in just a moment. First, I'd like to just go around the Zoom squares here and have everyone give an introduction. Of course, I'm joined as always by Dr. John Borerro, Editor-in-Chief of the Journal of Applied Behavior Analysis. And we're going to be talking about a study. We've got the study's authors here, and I'll let you guys introduce yourselves. So Manish, do you guys want to take it there, and then we'll move over to Brennan?
Absolutely. So hello to everyone. My name is Manish Vaidya. I've recently retired from the University of North Texas as faculty and chair of the department, and am now the executive director of the Institute for Behavioral Science and Technology in Rehabilitation.
My name is Sachen Mehta. I'm an orthopedic surgeon in private practice for about 25 years now. My practice is called Comprehensive Orthopedics and Rehabilitation in Richardson, Texas. I specialize in sports medicine, but also have an interest in joint replacements, particularly knee and hip replacements.
I'm Brennan Armshaw, faculty member at West Virginia University in the psychology department, primarily in the behavior analysis department area, with primary focus of research in behavioral medicine and neuromuscular activity.
Great. And you guys just published this excellent paper. I'm going to say the title and you guys can correct my pronunciation, but it's surface electromyography-based biofeedback can facilitate recovery from total knee arthroplasty. Did I get that at least in the ballpark of correct? Okay, great. I think as some of us behavior analysts are getting older, these topics are getting a little bit more, personally relevant, and but more generally, this is again a very interesting application of behavior analysis. And usually, a lot of the topics that we cover are, more so related to things like supporting individuals with developmental disabilities or organizational behavior management things and other sorts of things. And this is an interesting topic. And I know you guys did a kind of a pilot study that we talked about actually, and I think it was Inside JABA 8. We can get to that as well. But I want to maybe zoom out a little bit and just get a brief background on the problem itself. So maybe we could start there in terms of talking about the issue at hand here. The KOA, and that acronym has been referred to many times in the paper. And so what is KOA? What do we know about it? What is the progression of this condition? And maybe walk us through the standard of care for it and maybe some of the challenges that goes along with that.
Sure, I'll take that question. KOA stands for knee osteoarthritis, which osteoarthritis is a progressively worsening degenerative condition in the joint. It can happen in the knee, but it happens in every joint. Actually, there is some inflammation. There's an inflammatory component to it. It progressively worsens as the patient gets older, and it causes disability. It causes pain and swelling and stiffness, difficulty walking, climbing stairs, kneeling, squatting, basic overall reduction in quality of life. It's extremely common. Something like 30 million people in the US have osteoarthritis of the knee, and something like 500 million worldwide. And I would guess that both of those numbers are somewhat low, due to underreporting. But it's the number one cause of disability worldwide. So it's a big problem. And we see it every day in the office, and we're working on treatments. And so, the currently available treatments are, they're good, but not perfect, obviously. And so there's certainly room for improvement. Arthritis, people, you might say, well, what causes it, or how do you get it? The cause is multifactorial. So it means age is a big risk factor, weight is a risk factor, injuries that you may have had when you were younger, or activities that you may have done, even surgery. Like people who've had multiple surgeries in the knee are more at risk for arthritis than people who haven't. Genetics is a big one. Even things like the alignment of your legs. So if you're bow-legged or if you're knock-kneed, that puts more pressure on one side of the joint or the other, and that can lead to a wearing out of the joint due to the malalignment. And then, of course, gait abnormalities and muscle weakness and lots of other things that contribute to the development of arthritis.
Given the prevalence in there's got to be a lot of information about what works to address these issues. Can we walk through that a little bit and then maybe tie that into the rationale for the study that you guys published in this issue of JABA?
So, the treatments always start conservative, and things like topicals, like Biofreeze, Voltaren ointment, and things like that. And then you get, to bracing with knee sleeves and what are called unloader braces, which help to shift the weight from one side of the joint to the other. Weight loss for people that are overweight. And then it goes to medications like Tylenol over-the-counter or anti-inflammatory medications, either the over-the-counter ones like Aleve and ibuprofen or prescription anti-inflammatory medications. and then physical therapy and or a home exercise program. And that probably is the number one most effective long-term treatment for osteoarthritis of the knee. And so we really try to emphasize that one. It's the one that has no side effects and, very safe, effective. It's typically effective over the long term, unlike some of these other treatments that we do. So we really push that, and it works when people do it. But getting them to do it is of course the challenge. And then we move on to things like injections, and there are different kinds of injections, including cortisone and anti-inflammatory medications, something called PRP, which stands for platelet-rich plasma, which is kind of a newer treatment. And then ultimately surgery, of course.
Okay, so the context of this paper is it revolves around the latter option. So what are the conditions under which people qualify for surgery? I would imagine that if they're not able to lose weight and they're not, able to be consistent with a home exercise program, the medications are either causing other problems, they're contraindicated in any way or in some way or something like that. Am I kind of getting in the right direction? It's like you got to go through these kind of gates, if you will. And so it's not like you just show up and say, I've got this condition and then you're getting scheduled for the OR.
Correct. Yeah. No, so that's exactly right. We go through the progression of conservative treatments, but you're right that, many of them have contraindications for example, people who've had bleeding ulcers in their stomach or have reflux or kidney disease are not good candidates for anti-inflammatory medications. People who have contraindications to steroids, wouldn't be able to get a cortisone injection, for example. So, yeah, we have to sort of moderate those conservative treatments. But in general, we go through them all, skipping the ones that are contraindicated for people. And then the decision to proceed with knee replacement is really a quality of life decision more than anything else. So it's failure of conservative treatment when all of the other conservative treatments have failed, and when their quality of life is affected in a way that is unacceptable. And so general parameters, these are very general parameters, but for example, if a patient can't walk 30 minutes without having to stop and rest, if you can't walk 30 minutes, you pretty much can't even go to the grocery store. I mean, your quality of life then starts to really go downhill. Or you can't sleep at night because every time you roll over, you feel your bones grinding together, and that significantly has a negative impact on your quality of life. Or if you are falling or afraid that you might fall, every time you take a step, you feel the bones grinding together, and you either go down, hit the floor, or you feel like you might. Those things also are just such a severe impact on your quality of life. And then deformity is a sort of secondary factor too. If a patient is severely knock-kneed, as that knock-knee gets worse, that can get harder and harder to correct. So we will sort of skip some of the conservative treatments in favor of surgery if a deformity is getting past the point where we're able to correct it.
Got it. So,
I'm sorry. I can talk a little bit about knee replacement. Knee replacement, the surgery is basically a resurfacing operation. So we shave the ends of the bones off and put caps on the ends of the bones. So there's a metal cap that goes on the end of the femur, a metal and plastic cap that goes on the end of the tibia, which is the lower bone, and then a plastic button that goes on the back of the kneecap. And so instead of bone against bone, it's metal on plastic. That's basically what a knee replacement is.
I see. And just out of curiosity, do those parts wear down? In other words, if someone has a knee replacement at, 60, 65 years old, are they going to need another one at like 70, 75 or something like that?
That's right. They have a limited lifespan. In general, we like to say that 80% of knee replacements will still be good at about 15 years. It's probably better than that overall, but those are the historical numbers. But as the years have gone by, things have gotten better. So, the knee replacements that we're doing today, we don't really know exactly how long they're going to last.
I see.
The goal is for replacement to last the patient the rest of his life or her life. I mean, that's what we strive for, obviously.
I would imagine there's probably a lot of lifestyle factors that impact the variability of the
sure.
Not just the rehab itself, which we're going to get into here very shortly, but also the lifespan of the operation.
That's right. And so there's recommendations on what activities are allowed, after knee replacement. So in general, we don't like people to do impact activities like running and jumping and things like that. We know that patients are able to do those things, some of them, not all of them, but we recommend that they don't because it wears out their knee faster. And revision knee replacements, like taking an old one that's worn out, removing it and putting a new one in, is a much more difficult surgery with a much higher complication rate and a lower lifespan. So that's not preferred if it can be avoided.
I think both myself and the listenership, we're grateful for that little explainer on all things knee replacement. So I very much appreciate that. So let's tie that into the paper. In the paper, actually, I'll leave it up to you guys where to begin, because there's this discussion of the VMO. And so firstly, we need to know what the VMO is, right? And why that's important. And then there is a very important paper, the pilot paper that was published in 2021, also in the pages of JABA, which I'll link to in the show notes. I'll also link to the Inside JABA podcast in which we discuss that. So I'm curious where you guys want to kind of pick up the story from here, now that we've got a foundational understanding of the problem of knee replacement.
Yeah. So, actually it's a perfect place to pick up the story. Where we began to get involved was with respect to post TKA recovery, post knee replacement recovery. Was we ran into some literature that said that a large proportion of patients, in one paper, about half the patients don't gain full functional recovery for up to a year after surgery. And it seemed that there were some pointable at reasons why that was happening. One of them was this muscle, the VMO, or the vastus medialis oblique. It's one of the four muscles that makes up the quadriceps. It's primarily responsible for the extensions and flexions that the knee joint engages in. If that muscle isn't strong, you don't have the range of motion that you need, and a lot of other complications. Actually, I should let Sachen talk about what those complications are, but I'll just say that our interest was in are there behavioral factors that are getting in the way of this recovery? And as we began to read the literature, what we found were some problems that, it seemed to us at least, were fairly straightforwardly interpreted as behavioral issues. A loss of proprioception, slight loss of proprioception, for example, looks a lot like sensory extinction. You're engaging in the response, but the feedback isn't there. The natural feedback from the body that a muscle's being engaged isn't there. So we thought that's a factor that may play a role. Pre-surgical atrophy of the muscle, people just avoid using the muscle. You can almost make out a characteristic gait pattern when people are avoiding bending the knee. They sort of swing the leg around, and that results in atrophy of the muscle. So again, in behavioral terms, what that means is that it's going to take more effort to engage in the response. So these were the factors that we began to focus on, that behaviorally we could see that the response was made more difficult, that the response wasn't getting the actual feedback that it should be getting, and fundamentally a contingency of reinforcement had been compromised between the action and the outcomes that the action typically produces. And so that's where we began to see a role for behavior analysis in creating supplementary contingencies of reinforcement that might sort of fill the gap between the body's natural return, the return of proprioception and body's natural feedback systems kicking in, that period between surgery and the return of those. That's where we thought there was some room for us to step in. And that's what the first study, even though it was done with healthy participants, the idea was, are we going to be able to measure the activity of the muscle with the surface electromyograph? And then simply, will we be able to reinforce it? Will we actually see reinforcement? So that was the start of how we got started on this journey.
Hey, folks, I just want to take a quick break here and remind you, in case you missed it at the beginning, that these Inside JABA Series podcasts, along with many other of your favorite behavioral observations episodes, are available for continuing education. So if you want to see how that works and what's available and things like that, go over to behavioralobservations.com/get-CEUs and see what we had to offer. Okay, so let's take a quick recap of that 2021 paper then. So if you can provide us with a little bit more detail about the nature, the pilot nature of the study and what you did and what you found.
Yeah. So in that, as Manish set up so nicely, what we were really trying to do is show whether or not are we able to establish sensitivities to the contingencies at that neuromuscular level. And so in that study, what we did is we compared within subject whether or not we saw differentiation in the intensity of that contraction. So how hard is someone is going to contract that muscle, whether there's no contingency in place, we just tell you to go ahead and flex your muscle. Whether there is a contingency in place, you flex that muscle, you meet a certain amplitude value, flex hard enough, an auditory tone is produced. And then we also had a third comparison in that study where we put it inside what we called at the time a gamification sort of approach, and gamification in the loosest sense possible, where there's an auditory visual sort of component and really like that carnival game where you swing a hammer, but it's just the ball goes all the way up to the top, and whether that would lead to even more improvements or greater contraction. So how hard will you flex that muscle? And in that paper, what we found was, firstly, there was a difference between no contingencies and contingencies. And even more so, that when embedded in this auditory visual or gamified sort of contingency, there was even greater contractions produced, and more readily did they meet the goal they were set. I think one of the interesting parts of that study that we did, besides one determining whether or not there was a sensitivity to the contingency, was along the way we sort of stumbled into this process of, well, you need to know where to set that contingency. And the literature surrounding how to determine goals using electromyograms is a little bit fuzzy. Usually it's something called what they call a maximum voluntary isometric contraction, which basically is a procedure where you give it instruction and say, go ahead and contract as hard as you can, contract as hard as you can, contract as hard as you can. And under that instructional control, whatever the greatest amplitude produced is what you determine as their maximal capacity. When we looked at some of the literature surrounding that at the time, we started to find that there was large gaps with once someone moved into an exercise or a contingency, they were exceeding well beyond what one thought was their maximum. This is another point I think was exciting as a behaviorist. It's like when I saw instructional control only, not embedding in a contingency, I'm like, well, using a contingency seems to make sense. This is, I think, where we start to can blend behavior analysis and see how it fits across different domains. And so what we did there was kind of develop a procedure where we established a brief history of reinforcement, where it was a progressive sort of schedule, where it was an easy, medium, difficult sort of requirement, each producing a reinforcer auditory tone. And then we removed that using extinction to see if we could get a burst-like effect and capture that as a way to get a more accurate measure of their maximal contraction. And then we use that to set your goal during the exercise contingency, where we looked at those auditory versus auditory visual versus no feedback.
I want to jump in there and say that was one of the most elegant behavioral preparations that I have seen in a long time. I read that in my class. My students and I just couldn't stop talking about it. How freaking cool is that? That instead of just asking you how hard you can flex, we're gonna expose that particular response to extinction and then see what the participant can give us. It was brilliant. I'm so glad that you highlighted that because it's one of my favorite features of this line of work.
Oh, thank you.
We're very hopeful that that's going to be something that the rehabilitation folks will take very seriously. It's funny, in the literature, you regularly get 150, 200% of MVIC. And MVIC is supposed to be the maximal. And so clearly we weren't getting the maximal. And really, this is just a journey to get a better estimate of what the muscle's capable of. I'm not even convinced that it was a fantastic thing. But there's still room to figure out how big should those steps be, those first three reinforced steps? How much should you stretch the response, so to speak, to really get the maximum? And what's beautiful, John, as you said, is that it requires us to dive into and understand extinction better than or differently than we've understood it so far. And so that there's a really neat component to this, that while we are able to contribute to the applied side and to grow quality of life and things of that sort, there's still so much room sort of to really be enriched by the basic understanding of behavioral dynamics. So yeah, we were as excited as you were.
I used the same exact words that you did. I mean, I thought it was absolutely brilliant. Just the technique of trying to produce this maximum contraction.
And it sounds really cool because sorry, go ahead, Matt.
So I want to take a step back and just make sure the listeners understand. So there's a device on the knee that is measuring the contraction. So that's generating the feedback.
Correct. Yeah. And what's happening is I'll just say quickly, yes, there's a device on the knee, and we're arranging contingencies. Once you exceed a certain amplitude, you will hear feedback. We do that on 3 trials, and we slowly increase the requirement on each of those 3 trials so that they're, loosely speaking, working a little bit harder than they did last time. On the 4th trial, we set the requirement so high, they absolutely can't reach it. And the goal was exactly as Brendan said, could we tap into what we call the extinction burst there and see a better estimate of what that muscle's capable of?
So even slightly further back, I guess, I think I'm assuming surface electromyography, everyone knows this. And then I have students who come to try to join my lab, and I ask them, have you ever heard of surface electromyography? And they're like, what? No. So it's a technology that measures the electrical activity flowing through our muscles when we engage in the contraction. And so there's a correlation between the greater that electrical flow through a particular muscle bundle, the greater amplitude produced, and the more force that's being output. So the surface electromyograms is a device that lays over the surface of the muscle on the skin and allows us then to measure that activity. And then we use that to then arrange contingencies in an app-based form.
Perfect. And I think everyone's on the same page now. I appreciate you guys going into a little bit more detail about that. Go ahead, John. I'm sorry I cut you off for the second time.
Thank you. So what I have to say, I'm not sure if I'm alone in this, but one of the things that I found so interesting is, maybe you can provide some context for this. How is this type of feedback and technology not common practice? Or is it? Is it the case that when you go into your therapeutic sessions, your therapist is telling you, flex as hard as you can? Or is this kind of feedback that is described in the 2 papers that we're talking about today, is this the norm? Is this common?
Can I give just a general sort of overview of that question? One of the most important factors in recovery after knee replacement is building and maintaining quad strength. It's the critical piece of this puzzle. It's what every surgeon sort of knows and tries to impart that wisdom into their patients in order to get a good recovery. Patients are always looking for the best implants and the best surgeon. Those things are important, but the most important factor is how hard they work at their rehab. And so motivating them and getting them to do their exercises is a critical piece of this. So I've wondered why this hasn't been a thing before, which is sort of your question. Like, why wasn't this done 10 years ago? And why are we just now stumbling upon this thing? It's so critically important. So, but that's where we are. And that's why I think this is so valuable.
Yeah. I think we had a similar question and dove into like a review of looking at what has been done surrounding surface electromyographic biofeedback historically. Why hasn't it been more readily adopted? I think when you start looking at some of this literature, what you find is there's some variability in effectiveness when it has been implemented. And to almost always just in a research-based paradigm, never really considering some of the clinical implications or how it would embed into clinical workflow. I think we'll probably talk about that a little later. But what you found is this big gap, sometimes effective, sometimes not, really seems like a flip of a coin. So I wonder how much that contributed to it. As we started to look at why that might be, I think as a theme to everything we probably are going to talk about is forgetting the contingencies. It's not behavior analysts who are doing this sort of work. And so when they think about arranging goals, oftentimes what's done is it's used, well, in the best cases, it's using that old MVIC procedure where you just instruct someone to try as hard as they can and you set the goal off of that. And oftentimes what you find is that then remains your goal for the remainder of that study. And so you have a goal from day one where you're fresh out of surgery, and then that goal often remains the same when you're 6 and 8 weeks out of surgery and have made substantial gains in recovery. So I think that forgetting those contingencies might contribute to why it hasn't been more readily adopted or why the effectiveness seems to be more variable at times.
And to Manish's point, it's also the case that, if I understand correctly, when we ask you to do that maximal flex, we know that that's 200 times less than you are capable of engaging in, which is what is manifest in that extinction trial.
Yeah.
Yeah.
There are some other factors that are playing a role. The technology has really been around since the early 1900s. And back in the 60s and 70s, biofeedback had become very, very large, and it was being used in a variety of contexts. Here's what I've learned about what I think are some of the barriers. When we've actually spent time in the clinic with the therapists, we notice how busy they are. They're dealing with multiple people, multiple repertoires within individuals, and they're having to manage really a very intense workload. And in that context, anything that requires a little bit of time away from patient, for example, to set up a surface electromyograph, that detracts from utility in the clinic. If you have to do analyses after the fact to see where the responses were, that detracts. And so when we first walked into the clinic, we said we can give you these very detailed reports. The therapists very honestly said, we're not going to be able to look at those. It's not going to work. And so a part of I think what'll help bring this technology into regular use is attacking some of those barriers, making the technology more readily available, making it so that you could walk in, for example, slip on a watch and get to work, as opposed to some of what it takes now. So some of those things are barriers as well. Brennan's absolutely right. The work that had originally been done wasn't being done with the kind of sophistication that we would think would be important from a behavioral perspective. Like we would say, you got to have baselines. How can you know where you are if you don't have baselines? Some of the work wouldn't take baselines. They would just jump right in. And so it was hard for them to evaluate the successes. Some of that certainly has contributed to adoption of the technology, but I feel like a bigger barrier has been the availability of an easy technology that seamlessly works into the clinical workflow. Once we start to get there, I feel like we'll start to see more ready adoption. I think the utility of it is recognized. We have to make access to that utility. We have to reduce the cost of that. And I think that's when we'll start to see adoption.
I mean, I think that's how we get it, maybe get it going. But ultimately, if we prove, if we can show better outcomes, that's really what it boils down to. If we have patients that are recovering faster and better and less pain, then the therapists will make time for it. I mean, they happily make time for it. I mean, that's really what we're trying to do, is get these people recovered and get them better. So
I'd like to return to this because I think there's a lot more to say on what's next. But I'd like to maybe transition to because we covered the problem, we covered the research that was done in 2021. Let's get into the 2024 paper and the current issue. And I think that'll make the discussion of where things go from here. What was the goal of this particular study? And I think we've already talked about some of the variables, but if you can kind of tag those independent and dependent variables for the listener, again, just so we can develop some, repetition and, enhance our understanding of what you guys are doing. And then certainly talk about some of the just awesome results that you guys got, because it really is cool.
Yeah.
I'll skip the first part and then let Brennan take over the rest of it. Our primary goal was to see if we could step into the clinic and do this work with patients who actually need it. So that was the reason for the big difference between the 2021 study and the 2024 study is that the 24 study is being done. It was conducted with patients who had just undergone knee replacement surgery. I'll let Brennan take over the details from.
Yes. So yeah, as Manish said, like that's the big goal here. And then to show whether or not does this sort of approach, this surface electromyographic biofeedback approach, lead to better outcomes than more standard neuromuscular electrical stimulation. So which is this a device that again goes over the quadricep, but this provides a stimulation. There's electrical pulse that goes through and causes the muscle to contract, versus the electromyogram would be patient driven. So you have to engage in that contraction. So what we did here in this study is we wanted again to like keep in mind clinical flow, not take away from patient time. So it was a group design study where one set of the participants received our biofeedback only in one portion of the exercise, the exact same exercise that patients would otherwise receive neuromuscular electrical stimulation, which is a quad set exercise where they just lie flat on their back, their legs extended, and the neuroelectrical stim will contract that muscle for them for 10 minutes. That's one group. And then our biofeedback group, conversely, would engage in the same sort of contraction, 10 seconds on, 10 seconds off, just like the stimulation would provide, but they're all driving back, again, 10 minutes. And so we looked at the effectiveness of that procedure relative to performance in the neuromuscular electrical stim group or our control group across 4 dependent variables. Quad strength. So we measured using our strength-based assessment, that RMVIC procedure, where we just put that inside the contingency split to see how hard you can actually contract. We measured range of motion as a secondary measure. We measured a functional measure called the timed up go, which is a pretty fun, a cool procedure. I was excited when I saw it from a functional standpoint because it really seems to capture in a really brief period of time a lot of the things you would do in your daily life, where a patient has to sit down, go from a seated to a standing position, walk across, so engage in a normal gait, turn around and walk back, and you take a duration of how long it takes to go through all of those sorts of steps, kind of getting at, are we moving towards functional improvement, increases in quality of life? And then we looked at a qualitative assessment, short form 12, which asks questions about how much is this impacting your life? Are you seeing improvements? Are you going back to regular activities or not? A range of questions trying to get more qualitatively at changes again in that quality of life, because we really wanted to keep that as a focus, since one of the big gaps is a 50% return to a similar quality of life.
Got it. Yeah. That getting back to that functional, the get up, get and go. I agree. I thought that was one of the cooler measures here. And, when you're looking at, duration and trying to drive that down again, I think you alluded to this earlier, like as a behavior analyst, there must've been all sorts of things pinging when you discovered this outcome measure. It's like, oh, we could probably do something here. So that's, or at least that's what was going on in my mind. So very cool. So that was a very, very good walkthrough of what you guys did. So let's talk about what you found as a result from this.
I think our strength-based one, which is our primary, right? That's the primary DB. That's one we intervened on because we were focusing on quad strength. Nothing we did really targeted range of motion. We thought we would see improvements in potentially the functional measure, that timed up go. What we found was a pretty substantive increase in strength of the quadricep, with patients in our biofeedback group outperforming those in the standard of group, that neuromuscular stim, by 3 to 6 times the amplitude production from a measures of change from baseline. So we're really excited about that. If I'm being perfectly honest here, was a little surprised because we also saw pretty distinct improvement in range of motion and the timed up go performance despite not intervening on it. So I think begins to allude to potentially this faster change in strength improvements potentially had this led to improvement across how they performed other exercises in the clinic, how they were able to engage in balancing activities, whether they were walking more in their daily lives. Again, this is me like thinking what might explain why range of motion and things like that led to a greater change.
And I think that underscores what Sachen was saying earlier, that it's all about quad strength. Once you've got good quad strength, you're starting to see these kind of trickle down or other cascading benefits of the strengthening approach.
That's exactly right. It's all about quad strength, and it's all about how soon after the surgery you can get that quad strength back. The sooner, we're in the clinic seeing these patients, and my PA, my assistant, will sit with them for 5 minutes and just have them contracting their quads, within a day of having the surgery, and the therapists in the hospital are doing it within hours of having the surgery. So the sooner they get that back, the sooner they're starting to activate the muscle, the quicker the range of motion comes back. We see that clinically, and now we've shown it to be true as well.
I should note that even though most behavior analysts don't have a good background in groups designs, the results do kind of jump off the page. So if you're listening to this and like, oh, this is a group design, not my wheelhouse, don't let that be a barrier to checking this study out, because again, the outcomes literally jump off the page. I'm looking at it right now. And what's particularly interesting is the figure 2. If I'm reading this correctly, some participants in the neuromuscular condition actually got weaker. Am I reading this correctly? Or at the very least, you could see like the rate of change is off the charts for the experimental condition compared to the other 2.
Yeah, you see for like 2 of those participants, a very slight like decrease in performance from beginning to end for that neuromuscular group.
We've actually replicated that with healthy participants in another study that we're writing up now. It's an interesting observation, actually, and it's a very interesting finding. And we've been trying to figure out, what may be going on here. Dr. Mehta has mentioned to me that a standard of care following knee replacement used to be a machine called continuous passive motion. CPM. It would just sort of help you flex and extend your knee. That's not being used so much nowadays. Some of the things that I've read suggest that it wasn't quite as helpful as it had originally been thought. What's really interesting here from a behavior analytic perspective is the role of operant behavior, right? Voluntary activation. So the big difference, it seems, is that when we ask people to engage in the response and then provide reinforcement, they engage in the totality of the response. And what we're learning is what that means is, for example, small muscle bundles fire first, the larger bundles fire a little bit later. There's an entire sequence that appears when we ask for voluntary engagement. When we do passive stimulation, we don't get that same sequence of activity. All sizes of bundles fire all at once, for example. And so there's a sense that we may not be teaching, while we are definitely activating the muscle and waking the muscle up, so to speak, we may not be teaching the patient how to actually engage. So that, we feel, is perhaps responsible for the fact that the NMES subjects are sometimes showing either no gain or sometimes even a loss, of muscle contractile strength.
There's 2 points there. I think one that you mentioned, and I'll just summarize, that active is better than passive, just generally. That's the theme in orthopedics, and that's true for trying to regain range of motion. That's why the continuous passive motion machine has sort of fallen out of favor. It's been shown to be ineffective, and alternative strategies that involve active participation are better. And the same is true with the neuromuscular stimulation, which is passive. It's really the patient just laying there and letting the machine contract their muscle for them, versus actively doing exercise with the biofeedback, which teaches what you were alluding to is called recruitment, which is a sequence of activation of the muscle fibers, and neuromuscular training, which is almost like coordination. There's some proprioceptive benefit to that, and a coordination, I think, is a good word, as far as what they're learning from that. So that's way better than anything passive.
What did you learn from the qualitative outcomes?
So I think the qualitative, the short form, provide us some evidence of, one, they're actually noticing differences in their daily lives over time. Anecdotally qualitative, I think, is another thing that I think we learned a lot from, is like being in that clinic day in and day out. I think one of my favorite motives, and I think this is why we should probably care more about qualitative stuff going forward as behavior analysts, is I remember a very vivid moment with one of the patients I was working with at the time, and he would occasionally, he would hide behind when he saw me come in, he would jokingly hide behind the exercise thing so I couldn't find him. And then he'd come on out. And then when he was about to be done with the procedure, he was like, he was distraught. And he was like, but this is how I work the hardest. And I feel like I can see how I'm doing. I was able to start like tacting these differences and like describing like this is a big part of why he's, starting to show up every time when he has his appointment, because he's seeing his progress, seeing these sorts of things, which was interesting to me from a qualitative standpoint, because it was contrast in the same exact sentence, which this is what's the hardest for me. And so I think it really kind of highlights that it's not necessarily when we're working with these patients, I mean, without the qualitative and attending to some of those cues there, I would usually think, like, how do we make this more fun? How do we make this less work, but still get the same sort of outcome? Here, the effort wasn't a problem for him, at least not relative to seeing his change in performance and actually being able to have some onus and control in his recovery process, at least in a more salient way than it would typically be seen.
I was so pleased to see the short form questions in this manuscript. I would like to underscore that I think that there's an opportunity for behavior analysts to incorporate more of these qualitative instruments and approaches in therapeutic behavior change arrangements. If I can link this to something that is quite common in the journal itself, evaluations of behavioral interventions for persons with disabilities could benefit from these sorts of approaches. Parents and caregivers, are you seeing benefits to this behavioral intervention that you're experiencing? And I would love to see us incorporate more of those across the spectrum of behavior analysis. So as a clinician, you're constantly seeking this feedback from the individuals you serve. And I think if there's a way to incorporate that into our scholarship, then the potential contributions will be better recognized. So beautiful addition to the study. I'm very glad to see it. I hope that continues as you move forward in this line.
It turns out that these four measures are a very common cluster in rehabilitation work. Just about anything that you pick up, people will be measuring these four things, especially in work related to the knee. So I'm glad that there's a recognized value in that. There's another measurement tool called COOS. I can't remember.
Knee outcome observation score or something like that.
And that's been normed across a large population. We're thinking about beginning to use that so that we can connect up with an even larger literature.
I have two questions. You can take them in any order you want. I guess first, and Sachen, I don't know if this is probably more your wheelhouse, I suppose, but is the general principle of adding strength to a muscle group, does that translate to other areas of the body? I would just assume it would. And then I guess a second question or a related question to that is that do you see this being explored for hip surgery or rotator cuff surgery or some other type of rehabilitative intervention that also is well represented in society, much like the incidence of TKAs out there?
Yeah, 100%. And we've already thought about these things. You hit one of them right on the head. The rotator cuff for shoulder surgery is the key muscle in rehabilitation of a lot of shoulder problems, but especially in shoulder replacement and also in rotator cuff repairs. And for hip replacement, for example, the abductor turns out to be the key muscle. So the gluteus medius and minimus, those muscles are the ones to target. Nowhere is it as laser focused as it is in knees. In knees, it really turns out to be the quad more than anything else. There are other important muscles, of course. I'm not trying to downplay it, but the quad is kind of the most important muscle to target. In other areas, there's a wider variety of things to target, but still there are kind of important muscle groups that we know if we can improve the quality of the rehabilitation, it would dramatically improve the outcome for the patient.
And a related question, I guess, is that it seems like, again, we've highlighted the fact that strength is the one ring that rules them all, if you will. And I'm wondering if I want to get into talking about other studies, and perhaps in doing so, we can get into dissemination, John. But would that be the most parsimonious metric moving forward? In other words, by establishing strength as the primary factor, would that make both research and perhaps more importantly, clinical practice more efficient down the road because, okay, we've seen that increasing quad strength or increasing strength elsewhere in the body, assuming other studies generate similar findings, has all these spreading effects across range of motion, getting up and getting down, qualitative outcomes. So at least for the purposes, of efficiency, let's just focus on building strength for this particular muscle group.
For 25 years, it's the thing that I have been pushing our physical therapists to try to laser focus in on, which is strengthening, basically strengthening. There are, again, I tend to, maybe overstate to some degree, but, range of motion is important. Gait abnormalities can be fixed. There are lots of other things to work on, but over the long term, for many conditions, strengthening seems to have the biggest benefit. And so I'm sometimes frustrated by patients who go to physical therapy clinics and they come back and I say, what kind of strengthening exercises have you been doing? And they tell me a list of exercises, none of which have any kind of progressive resistance component to it, which is ultimately what results in strengthening. And so, long term, we don't see the improvement that we're hoping for. And so then we send them back and say, listen, we want them to focus on this, make sure they focus on this particular thing. And sometimes involves a discussion with their physical therapist. So yeah, strengthening is the key for most conditions. And, we're talking mostly about knee replacement right now, but almost any condition in the knee benefits from quad strengthening. So, for example, quad strengthening, as we discussed, helps people with knee arthritis even before they've had surgery. It helps people who've had arthroscopic surgery of the knee for a torn meniscus or many other conditions that's done for. It will dramatically help people who've had their ACL fixed, ACL reconstructions, and on and on and on. So, yeah, the application for this is almost unlimited.
Thank you. So, Manish, you started talking about a study that you've got underway or other sorts of things you guys are thinking about from a research perspective. I don't want to steal your thunder when you eventually share these data, but if you're comfortable talking about what you have coming up, I'd love to hear it.
Yeah, I really welcome the opportunity to talk about that. Thank you. I want to say one thing in relation to what we were just talking about, and actually I will defer to my very, very, expert partner here. One of the interesting things that we found with respect to the broad implications of operant conditioning and rehabilitation is that there is an entire, as we've just talked about, there's a lot of room for strengthening. We find that there are other problems where, I guess, hypertrophy would that be the word? The muscle is too active. And there's an entire round of work to be done to make the muscle less active. Shoulder strains, for example, when people are working on keyboards, we find that there's a lot of activation in the supraspinatus and these other muscles. And it's possible that finding ways to, via operant conditioning, to help those muscles relax, to provide feedback when there's less firing and not more firing, would also be useful. It's not something that we're going to dive into, but I just wanted to say that as we consider the role of operant conditioning in rehabilitation contexts, it's actually broader than just strengthening. It's really being able to address muscle state in an active, voluntary way, whether that involves relaxing the muscle or whether it involves actually working the muscle up and strengthening it. So I just wanted to kind of say that in the broad terms, there's a whole lot of work to be done on down training, just like there is on up training. Yeah, and I'll talk a little bit about what else is going on. Sachen and I have launched an institute to really focus on work related to behavior analysis, biofeedback, and rehabilitation. As I mentioned at the beginning, the institute is called the Institute for Behavior Science and Technology in Rehabilitation. We call it IBSTER when we're talking. And the focus there is essentially to try and drive development, innovation, and technology that uses behavior analysis and brings it to bear in a rehabilitation context. So we've got 3 different foci in the Institute. One, of course, is the VMO and quad strengthening. Another is pelvic floor muscle strengthening. There's a student of mine, Logan Gibson at UNT, who began doing some work in this area. We found that there are some muscles that sit slightly above the belly button that have a great deal of co-contraction with pelvic floor muscles. So when we see pelvic floor muscle contractions, these two muscles are also active. And what that's done for us is to create, this incredible possibility of a very non-invasive way to help folks strengthen their pelvic floor muscle. So we're able to put the surface electromyograph on this site called the TRAIO. It stands for transverse abdominis and internal oblique. It's the place where these two muscles meet up. And we're able to put the device on that to detect electrical activity generated there. And it turns out that when we say to people, contract your pelvic floor muscles, we see a lot of co-contraction at this muscle site. And we're able to then create contingencies of reinforcement, games for isolation and strengthening. So that's a focus. We have a paper that's just getting ready to come out. Again, using that same RMBIC strategy for muscle strength estimation, but we've applied it to the pelvic floor muscle in this case and not the VMO. And a third area of focus, it turns out, is found in swallowing. So we have some muscles right up under our chin here called the hyoids that are responsible for effective swallow, essentially. They help to cover the trachea so that the food properly goes down the esophageal tube. And when these muscles are weak, you don't get complete coverage of the trachea, and so you get food and water going into the lungs. In populations aged, older elderly populations or people that have had traumatic brain injury or stroke, this is a large problem that we are going to try and see if we can address. So we've made a point in each of these endeavors to make sure that the first conversation that we have is with an expert in the area. So we're working with speech and language pathologists who are experts in dysphagia and know just exactly what should be happening with the hyoids. In a similar fashion, we're working with pelvic floor therapists who have been doing this work for 30 years plus. And as I said, the first conversation is with them. What could we do? Is there a role for operant conditioning inside this mix somewhere? Can you help us find the operant, so to speak? And once all that happens, then we feel like our expertise can be turned on with respect to how to create contingencies of reinforcement, how to maximize the kinds of responses we're looking for. How do you drive differentiation? Things of that sort.
Awesome. That sounds like really, really cool stuff. So I look forward to hearing and reading about that as you make those data publicly available. I think now is a good time to, I know, John, you had some editor-in-chief questions, and then you wanted to talk about dissemination as well. So have at it.
Thank you. This has been a fantastic conversation. I guess for the listeners, I think it might be helpful if you could say a little bit about why JABA. And all I would like to add here is I thought that the two studies that you published in JABA so far represent a very natural progression. The first was, can we figure this measurement problem out? And the answer to that question was yes. No individuals were harmed because you had fully healthy participants. And then that begs the question, okay, but will this help people? And I think that your second study demonstrated that quite nicely. Selfishly, I'm so grateful that this work appears in JABA, but the impact that this work could have, as you've illustrated in your future endeavors, is so broad. I'm wondering if you could say a little bit about why you chose to start with JABA, and then what sort of distribution tactics you have in mind. So the study that you're talking about, what are the plans for where this work will appear? And have you given thought to a strategy to maximize your impact?
Yeah, those are fantastic questions. The JABA it seemed a natural home for us at first because our main way of interpreting the problem was behavior analytic. We didn't approach the problem as medical personnel. We're not medical personnel. And so the lens was behavioral. We thought, it makes sense. This is an audience that will appreciate extinction, for example, or loss of feedback, those kinds of things. The second one, again, it made sense because it was the application of a reinforcement strategy to this problem. We're definitely now seeing that we should be publishing outside of the behavioral analytic journals just to increase the impact. What I would love to have happen is for both sides to really benefit from this work. And by both sides, what I mean is it would be fantastic if applied behavior analysts began to see the potential for a considerable expansion of the scope of our science and discipline in this work that we're doing. I feel incredibly proud to be a behavior analyst because I feel like we're bringing genuine changes in people's lives in all the work that we're doing, not this stuff, but everything that we do. Here's an opportunity to further expand that contribution. And so that would be a real win. I think another big win would be if the rehabilitation folks began to see operant conditioners as genuine partners, as people who understood the nature of the problem and had the protocols and procedures in place to actually help. And so we want to approach dissemination in a very thoughtful way. The idea is, well, as I said, the idea is to get them to both appreciate the wine and the wine bottle, so to speak. There's a framework that it comes with, and that framework can be very useful, that this technology comes with. And it can be very useful for thinking about all manner of phenomena. And so it would be great if they didn't just get the surface electromyograph, but they got the entire operant conditioning framework that it resides within. And in a similar way, it would be fantastic if applied behavior analysts could begin to see an entire domain that remains unexplored, essentially, for expanding our science and for becoming even more useful to society than we've been so far.
This is always a difficult spot for me as editor because I want to make sure that the best of the best appears in our journal. So this is a standing invitation to keep submitting your work to the journal. But as a scientist and behavior analyst, I see considerable value in putting this work into the hands of those who perhaps need convincing or a bit of a nudge in order to compel them to adopt, as you say, both the wine and the bottle. So again, please consider the journal for your subsequent works on this, but outstanding work.
Thank you so much.
Thank you.
Have you presented these data at like an orthopedic or physical therapy conference or anything like that? And if so, what's been the reaction?
This is, at least for me, I can say like one of the big goals. Haven't presented at an orthopedics or physical therapy conference yet, but I have a colleague I'm working with, and we're recently starting a study looking at ACL recovery. I mean, he's a doctor of physical therapy in the health sciences over here. And so him and I are talking about picking and nailing down a conference when this data comes in to start talking about that data there. And we've been having some pretty great conversations about what are the best ways to talk about, particularly the behavior analytic perspective of things, and how we can translate that into language that'll be more immediately accepted, or at least click more saliently. So I think it's been a fun learning experience for me about how we talk about operant learning and contingencies across these different domains in ways that make sense, like attending to those moments when you're talking to a physical therapist and they have that, oh, okay. And so we've been talking a lot about how we can navigate this conversation from that sense. The data will talk for itself, obviously, but how can you get away from some of that jargon so it still is the impact of operant learning broadly, as Manish said, as like, can this be adopted as an approach? How we can make that seem more acceptable.
So it's a great point, Brennan. I'm super excited to get some of this into my world, which is the orthopedic world, and the physical therapy world for that matter too. We haven't, had the opportunity yet, but I'm chomping at the bit to make that happen. But I think what Brennan's point is true. Just as some of the lingo that I use in terms of the medicine needs explaining, and you don't like our acronyms. I think the same is true for me in the behavioral science realm. Some of the terminology needs explaining, and it would go a long way in helping people kind of get on board with this.
Yeah. Mm-hmm. We presented at ACRM, the American College of Rehabilitation Medicine, about 4 years ago, just a very brief talk on proof of concept. It was well received, but the idea was, yes, we know the benefits of surface electromyography. Let's see where this goes. We're scheduled again to present at ACRM in Dallas in November this year. Just a poster on some of the work that we've done, and hopefully there's a better story to tell this time about some of the implications. And so we'll see how that goes. But yes, one of the plans is very definitely to start going to the conferences where people need to hear some of what we're doing. Our RMBIC paper, for example, is going to a pelvic floor therapy journal. And so, as you have said, rightly, it's time to start making inroads into that literature as well. But we're very mindful. Again, I'll just say, at the risk of repeating myself, that we grow both sides of it really well. It would be fantastic if applied behavior analysts that listen to this or that see some of our work begin to think, hey, there's a possible future there for us. That would be fantastic.
Manish, one of the things that I think about often, you described submitting this work and publishing this work in a pelvic floor journal. One of the many benefits of that approach is that they're going to read the pelvic floor scholars and practitioners are going to read that journal, that article, and then they're going to come across this paper from a journal called the Journal of Applied Behavior Analysis. And then they're going to click that link, and then they're going to visit that site. And then those people are going to have their behavior exposed to what JABA has to offer. So I think about it, I use the expression frequently, cross-pollination, where we're putting our scholarship into their journals, and hopefully that may prompt others to bring that work to JABA. And then the work blossoms from that point. So again, very glad to see it happening in other journals as well.
Excellent. I think I've asked all the questions I'd like to ask. I'd like to give you guys the opportunity if there's anything else about the paper that you want to share with the audience that didn't come up naturally in the conversation, to do so. But if not, let me just reiterate my admiration for the work, and congrats on a really, really neat study that has lots and lots of important implications. So well done.
Thank you very much.
Thank you so much.
Thank you for the opportunity for this conversation.
Yeah, it's been absolutely fantastic having the opportunity to talk to you guys about all this.
Great. Can't wait to hear more. Thanks, guys. Okay, that's the end of our show for today. Huge thanks to these awesome guests for sharing this, frankly, groundbreaking paper. I look forward to seeing what they do in the future. And this is just such an amazing under-the-curve type of intervention that I would love to see more of in the pages of JABA. Again, all the paper details and author details and contact information, etc., will be over at behavioralobservations.com. Just look for the show notes for this episode. And if you want to get a CEU for this episode, we'll have information about how to do just that. If you are trying to get a CEU right away, right after this episode's published, give me a day or two to kind of get that configured. Sometimes that takes a little time, a little bit of sorting out. And I'm a one-man show with one hand right now, so I might need a little bit of extra time. But long story short, the CEU for this episode will become available hopefully in the next couple of days. And if you're listening to this well past the publication date, then this is a moot point. So, all right, that's it. Thanks for tuning in, and I'll see you in the next session of the Behavioral Observations Podcast.
Thank you for listening to the Behavioral Observations Podcast with Matt Sikoria. You can find Matt's notes on this episode at www.behavioralobservations.com. We also invite you to stay connected with us on Facebook at facebook.com/behavioral observations and on Twitter at Behavior Podcast.